So I was tasked with infections. So I've made a table of all the different topics and tasks that came up. This was the way I found it most logical to categorize them. So I've put here the context in which it came up, and then the particular infections that were talked about, and then the tasks. The tasks are pretty well in sort of descending order of most commonly asked, and then heading down. So I found it easier to think about sort of endophthalmitis. That came up a fair amount, mainly with acute post-op in a sort of clinical caveat, so bacterial ones. Fungal was mentioned particularly as a sort of aside to that. Chorioretinitis mainly came up with viral ARN, PORN. Life cycles of toxoplasma toxocariasis came up just a couple of times. That didn't seem to be a regular one. I could only find it once for systemic ophthalmic manifestations of syphilis and complications of AIDS. Keratitis, and it specifically asked 5 most common bacteria, 3 most common fungal, and then viral and acanthamoeba came up a couple of times. Congenital infections, TORCH wasn't specifically asked about. I've just put that in as a reminder for what infections those are important under congenital. CMV came up specifically, and then conjunctivitis, trachoma, onchocerciasis. So I hope that's a useful table for looking at what came up. So did I understand what they were asking? Yeah, I think the tasks were pretty straightforward for infections. They were straightforward. So the older questions were more generalized. So, you know, discuss the pathophysiology of X, but the later ones were more clinical. So you got a clinical scenario and then focus tasks beyond that following on. So one was discussed in terms of what I didn't understand. We'd sort of touched on it before, but it might be good for us to have a reminder of pathophysiological basis of, and then, for example, loss of vision in trachoma and onchocerciasis. So I did a practice question of one that came up in 2016, 45-year-old Indigenous Australian man presents to outreach clinic with poor vision, upper lid entropy and trichiasis worse on the right side. And then, like I said, it really did define and limit exactly what it wanted you to say. So likely diagnosis, clinical features, and pathogenesis. So the model answer, I used not Alistair's notes, the other one. And it was mostly a good answer, but it in the pathophysiology, it didn't cover the type 4 delayed hypersensitivity as part of the pathology. Rather, in terms of pathology, it was pretty heavy on the epidemiology risk factors, so sort of saying poor hygiene, close living quarters, flies, etc., body fluids, and it didn't actually say anything about the delayed hypersensitivity. So the examiner's comments for that particular question, well answered, and some did not provide details regarding pathogenesis. So a pretty general comment there. One of the questions for trachoma was classify effects, and just what helped me was using this WHO classification, which I think if you follow that, it does actually talk you through clinical, pathological and histological as well. So I think that's a very good one for trachoma in particular. So top tips. I think the later questions are very specific. So just make sure you answer the question and the task in the same order in which they're asked. And the other thing is the later questions, by later I mean, chronologically later, tend to put together the infection with the lab techniques for taking samples, the immunological basis and reaction against that infection, and clinical features. So I think it might help to learn about each infection as a whole rather than just, HSV and cut it there, to sort of learn about the whole clinical scenario.
I think that's a really, really good tip, Jess, because I've noticed that too, that they might give a short scenario, which is clearly an infection, and then ask you a lot of questions about it, which, as well as, histo, will be how to send it to the lab and associated things. I think so. Learning each infection in context is really good. I think it's also pretty good for practice as well, because generally you've got a fairly short differential diagnosis of what an infection is going to be, and you have to know what's happening and what to do with it. Other things that I've known, they've asked often about normal and abnormal flora. So you need to have a fairly good grasp of what's normal and abnormal flora in the eye so that you can interpret lab reports. So if they say they're growing X organism in their swab, does that need treatment?
So I think I've put that one in, one of my slides was, so under keratitis, I'll just share it again. I've got the exact thing they asked. Interpret result, gram stain, light growth of staph epidermidis, this one here, and how would you interpret that?
And there are other common normal flora that they might pop in there too. So good, great. Any other comments? Sorry, Chris, you're muted there.
That's not ideal. There we go. I find that one of the staph epi quite tricky because I remember asking a corneal consultant a little while back, if they've got a clinical keratitis and the scrape just comes back staph epi, do you treat that? And they said, well, staph epi can be pathogenic, in some cases. And so depending on the clinical picture, sometimes you would. So then you come to a question like that and you're like, ooh, I don't know. How do I interpret that? But I mean, from a path exam point of view, is the exam answer that it's a, normal commensal skin flora, etc.?
Do you have an answer to that, Jess? Have you?
Yeah, I will find the exact question. It did come quite specific, like at the end of a question about talk through how to do a corneal scrape or something like that. Like it wasn't, that wasn't standalone. Let me have a look.
So I think the answer that you gave, Chris, would be ideal.
Okay.
Normally you would ignore it, but in some clinical situations, it might be significant.
Sure. Okay. Ta.
Okay. So my schedule says that the next thing that we're going to do is, what do you know? Look at some slides. We're up to number 13. I will put you into breakout groups and we'll have a look at those slides and see what we see. I think this first one should be relatively short. So I'll go for a relatively short thing here. Just put you in threes this time for a bit of in twos. I'm just trying to keep you all awake here. Back to twos. Okay, off we go. Oh. I'll put you in 5 rooms. How's the day looking in Adelaide today, Mark?
It's pretty sunny today, actually. A bit of scattered rain, but still pretty nice.
Yeah.
Properly out of winter. Bring on the 40-degree summer days.
Yeah. Yeah. I was there in Adelaide in winter and it was pretty good, actually. I've only visited it in July, but it was all right.
You get lots of magpies there in summer. Are they just all year round?
Yeah, there's been a few swooping recently. There was a story in Melbourne, actually, of a guy unfortunately got attacked by a magpie in both his eyes, had to go to the Royal Victorian Eye and Ear and have it, I presume, it penetrating eye injury stitched up in the way they were describing it.
It was trying to eat his Chinese takeaway.
Okay, I'm going to bring us all together now. So I think it's my turn, isn't it, to look at this slide?
Must be your turn.
Alrighty, let's find the slide. So there was lots of really great discussion about, what kind of fungi were present in this slide. So that was really great. Let's just share the screen here. And I'll make it all go a bit further away. All right, so there wasn't any normal tissue that we could look at here. My guess was that this was probably a vitriol aspirate. Someone asked if it could be a corneal scraping. I couldn't see any epithelial cells here that might support it, but to me there was just a whole lot of inflammatory debris and these fungal hyphae, which you all recognized, which was really great. And then there was this discussion about what kind of fungal hyphae are there. So I discovered that that I was slightly wrong in I misunderstood mucor as non-septate. So the common ones, Cam, you've got an advantage here because they are named after you, CAM. And because we're all Australians and New Zealanders and love a bit of ribald kind of mnemonic, are we ready for the mnemonic? Right, here we go. C, Candida, is a non-branching fungus. Aspergillus, the A, branches at 45 degrees. Mucor branches at right angles and has irregularly shaped hyphae, some thick and some thin. All right, you want to do it all back to me?
Yeah.
That's excellent.
Okay, you'll remember that, won't you?
Aspergillus.
Yeah, no, sir. I was just doing my mnemonic for fungal hyphae. I wasn't being rude at all. So one of the tricky things about looking at fungi down the microscope is they cross each other all the time. Oh, sorry. My dad just wants the car key. And all right. So Andrew has the car key somewhere. Oh, the car is on the hose pipe and we can't water the garden.
Oh, yes.
So I don't know where it is. Sorry. All right.
Sure.
So what's the A for in Cam?
Right. Aspergillus, right? Candida, Aspergillus.
Narrow
mucor.
angle.
So they cross each other and it can be a bit hard to find, decide because they can cross at right angles, right? So I'm seeing probably some branching here that is 45 degrees. And yeah, I think there's definite branching here. There's another 45-degree branch here. There's a bit of a Y-shaped branch here. So maybe this is Aspergillus. I don't think it's non-branching. I don't think it is. It is Candida. I find that Aspergillus also kind of almost grows radially in long streaks, so that adds to my appreciation of it. Septate versus non-septate, I think you need a high power oil microscope to see that. There's another 40, oh, that's kind of almost a 90-degree branch, but that's 45 degrees. So I would guess that this might well be Aspergillus. Now, Aspergillus is black because it's stained with a silver stain here. So this is Gamori trichrome. What other fungal stain might I do? Let's talk about another fungal stain. Can you tell Amanda in the chat?
Acids.
Nothing yet. There's, I think in one of the corners, there's more like a tree-like growth at low power. You can see, I find that quite useful for differentiating mucor and, yeah, it's sort of like an arborizing, like coral, where you can see it's growing in that pattern, whereas zygomycetes.
Oh, here. This thing?
Or I think it's down a little bit, a rounded area. Yeah, that one there.
This is a really great aspergillus pattern. This is what I was trying to explain, where they all kind of go in one direction. Yeah, like coral.
Coral, yeah. Whereas zygomycetes is more all over the place. So we've been suggested PAS and GIMSA as other fungal stains.
I'll give a big tick to PAS. So in PAS, these stain bright pink. The PAS stains fungal cell wall. GIMSA, I've never used. In microbiology, I know they use calcifluor white to stain them. So those are the three fungal stains that I think have been used. If this was being sent to the lab, how should you send it? Does anyone want to attempt to suggest how we should send? So let's say this was an intraocular fungal infection and we wanted to find out what kind it was so we could give them the right antifungal. How would we send this to the lab?
So you can type and talk.
Just send it like soaked in like gauze.
On gauze?
Yeah.
It's like a vitriol aspirate in the little syringe that you use to tap, like a 1 ml syringe, or
Yeah. So how would you do your aspirate? Let's start with that.
so you can either do it with a needle with sterile technique through the sclera. Is this what you mean?
Yeah, so I'm thinking that it either ends up, I'll just stop sharing. So it's going to end up in a little syringe, isn't it?
Yeah.
How do you send that to the lab?
Put a stopper on it, call up the lab, tell them it's coming, and put patient details on the syringe and have it brought down in person.
All right, which lab do you send it to? Micro lab. Yes, you send it to good Nishan, you send it to micro. This is a micro sample, and if they have anything left, you could ask them to send it to histo. So what else do you need to put on the form if you're sending it to micro?
Where it's from.
Yeah. And
previous treatment.
All right. So in order to send it effectively to the lab, you would do a vitriol aspirate that you would keep sterile in the same tube by capping it. You would contact the lab and tell them that you were sending a fungal specimen, a vitriol sample, possibly fungal. If you knew that, what the patient's underlying condition was, what treatment they'd been having, and ask them if there's any left over, you can send it to histo. What if you sent it to histo first?
Wouldn't have any left for micro.
Yeah, they would fix it, or cytology. Yeah, they might put it in formal and then kill it. Well done. Yes, we would kill it. Okay, so if you've got something that you think might be microbiological, send it to micro first. They only need a little bit. There's often stuff that they can send to us. If you send it to micro after 5 o'clock, would this be any good? It might sit there all night. So send it to micro when the micro techs are there.
The other thing to consider is fungi. When it gets to the fungal laboratory, they prepare it by grinding it up. And sometimes with the septated hyphae, they don't like to grow from ground up parts. So zygomycetes, for example, are very slow to grow from ground up parts. So in some cases, it is the histology that saves the day, and we can identify the fungi are present, but we may not be able to subclassify them. That's where you need the micro. So you can have the situation where histology says branching hyphae, but there's nothing growing in the fungal cultures. This happens.
It takes a while to grow fungal cultures, doesn't it? Do you know, Amanda, if they use PCR now?
Yes, you can use PCR.
Yeah, I think they do. So that's good. So Juliana said, if you are sending an orbital biopsy to micro, send it fresh in saline soaked gauze.
Probably you don't need the gauze.
I don't think so. Or the saline, if you're close. Depends how far away from the lab you are, really.
Send it fresh, don't put it in formalin, right?
Yeah, just send it fresh.
Send it fresh to the micro lab if you want micro from it.
Yeah.
Were there any other questions about that slide? Anything else?
Do we know what it is, or we just?
It's aspergillus.
Aspergillus.
It's unquestionably aspergillus because it is growing in that coral-like fashion and is it's
does have,
guys, yeah. Okay. Yeah, I don't think there's anything else about fungi. Right.
yeah. And it would be unusual to get the zygomycetes or mucor growing in an anaerobic situation, which would be in your vitreous, whereas it's more common in like your paranasal sinuses where there's air so it can breathe, because zygomycetes is bread mold fungus, you know, that green stuff that grows on your loaf of bread when you find it at the end of the week.
Yeah, yeah, aspergillus is the black stuff in your bathroom.
Yes.
The only time I've seen mucormycosis in the orbit and eye is in diabetics, and then it's been in
From
vessels. Yeah.
Yes. Oh, yes. And probably coming from the paranasal sinuses coming up. Yeah.
Yeah. Okay, let's do the next one. I will pop you into breakout rooms again. Okay, we're all back.
Back.
I might sneeze. I might not.
A tissue.
Okay, let's think about. I think it's my turn, isn't it, for this one?
Whatever. Yep.
We are recording. We are recording. Okay, I will share my screen. Here we go. So we've got this eye, and we're going to look just at low power. We can see it's a globe with an optic nerve, and at the front of the eye, cornea is intact. One thing we notice here is a space. Yeah, that space is quite an interesting shape. It's a lens kind of shape. So it could be a real lens, though it could also be a plastic lens that was removed. Mostly the abnormality appears to be here in the anterior part of the eye, around where the removed lens was. Okay, let's have a little look at the back. So there's no cupping. The optic nerve appears to be like normal size. I can't see any masses, and there's no retinal detachment back there. Okay. So we think that the action's around this this lens-shaped space. Let's have a look at the cornea. So here we can have the cornea. We've got Descemet's membrane. We can't see Bowman's membrane. And the cornea is very, very full of inflammatory cells. As we move around here, there's this thick rind of inflammation. We've got some epithelium here, but the cornea remains really, really inflamed. Keeping going into the angle, we will have a look at that at the moment. We've got the ciliary body here. And the iris is so deeply involved in inflammation, it's hard to spot what's happening, but maybe there's some iris root around here. Let's have a look at what's happening. Can we spot anything in the way of the trabecular meshwork? Probably used to be around here. There might be a bit of an adhesion here. These were Descemet stops. But really the whole iris remnant is just coated in inflammatory debris and completely necrotic. So it's an intensely necrotizing inflammatory reaction with lots and lots of cells. Now, what kind of cells are they? They're mostly dead cells, is actually what they are. I can see some neutrophils here, and there's quite a few histocytes around. I did notice that here, I'll go back again, that's just here. Right, so there's the ciliary body, just here, there were some giant cells, which caught my attention, as giant cells do. And the giant cells seem to be reacting to a few things. So there's some refractile foreign material here, which suggests to me that this was a lens replacement, and the plasticky lens material has fractured a little bit. And then for the extremely sharp-eyed people, there are some fungal hyphae here. It's hard for me to tell what kind they are, and really, I wouldn't be able to tell what type of fungus this was without a fungal stain, just so I could see its branching properly. Here we go. This is the empty lens space around the back of the lens. Again, we've got, this is probably more necrotizing inflammation all over the place. Coming back here to the other angle, here's the ciliary body. There's a whole lot of necrosis here and around here. I'm not sure it adds anything new. Okay, again, we've got a few giant cells here. I actually couldn't find any fungal hyphae except for those ones I found.
Oh, we found some.
Found some more? Where did you find some more?
Or Johnny. We found some, and we found that interesting feature of the cornea.
Oh, this. Oh, of course, yes. This is the corneal wound. Yeah, so this is someone who has had a lens replacement. So this is probably a plastic lens that.
So just on the posterior surface of the cornea, on the inferior part, Yeah, around about there. Yes, there's more.
Hyphy?
Yes, a negative, maybe further up towards the centre. Where were they, Johnny, Juliana? Can't remember exactly where they were.
They're really
behind the central cornea.
behind the central cornea.
There they are. There, little refractile circles. Back. You went over them. There, stop. There.
Yeah, okay. Yeah, there they are.
There they are.
Yeah.
And look, there are. We found some proper branching ones.
Good. So we've got a branching fungal infection here.
Whereas it maybe down a little bit more, there was more morphology available. And so they're like negative. And we
yeah, they are a little negative.
Yeah. We saw the pigment, loose pigment had stuck to the outsides of it, making little brown branches, which were clear on the inside.
Yeah.
If you went a bit higher up, just next to the yeah.
I think we saw it with Lucy and I, mainly Lucy saw it just more that fibrous material in the anterior chamber, they're definitely branching hyphae.
In the anterior chamber somewhere.
Yeah, just there, but
Do you want to find them for us?
yeah.
I'm having trouble.
Yeah,
they're really hard to find, aren't they? Well, you spot them.
There they are in that piece of pus, just that's hanging off.
Yeah,
just a little bit over to the right of that. Yeah. Just go zoom in there and a little bit up to the up. No, it's off the screen now. Up, and then there. Okay, I can see it in the corner. Over to the right. Over to the right.
Oh,
there.
Here they are.
Yeah.
Oh, you little beauties. So they're definitely at 45 degrees, aren't they? So that's a nice aspergillus. Great. There's maybe
and probably in the white space, just at the bottom right, there may be the refractile elements of some of them that are non-staining, possibly.
Yeah.
Across a little bit more to the right. Yeah, to go there. That's on the back of
yeah, that's the one we saw.
Yeah, great. Good fungal finding team.
Team effort.
Yep. And then round the back. Everything's just looking a bit like inflamed and disrupted. I think there's no specific diagnostic features here.
We thought there's like some sort of retinal necrosis because there's destruction of the retinal layers. Would that be a fair comment?
So I can see here that the neural layer membrane here is intact. Let's keep going across the front.
It's edematous.
Yeah. The ganglion cells are not easy to see, but I didn't think there was retinal necrosis. I don't think there was retinal necrosis. So this was an endophthalmitis with evidence of previous surgery and a replacement lens that's been taken out before sectioning, and fungi with a granulomatous necrotizing granulomatous reaction on the posterior corneal and ear. That was pretty tricky.
That was a great case. It's like
great. Recognizing it as endophthalmitis, I think, was the important step, and then realizing the range of organisms that we could do this. So I would have asked for a gram stain and a PAS on this, I think.
So this is cataract surgery gone wrong. Well, complications of, right?
That's right. So is there a question in the chat?
Yes. Oh, Lucy. Why doesn't it look very blue? I thought inflammatory cells were blue. That's true.
Yeah. So it's a bit pink because the stain's faded. It's true. And also quite a lot of them are necrotic. So if you look down here into the non-necrotic bits, they're not really blue, they're just kind of dark. I'm going to stop sharing and next on our schedule. Okay. All right, so I think it might be time to talk about some of our other resources. Amanda, would you like to?
Sure, let's have a look at something.
Yeah. About other resources as you continue to revise.
And I would like to draw your attention to, I'm just going to do a screen share. Where are we? This book, and you can tell me if you have used it or not. This book is a clinical key book published by Elsevier, therefore it should be available via your DHB or university library because most of them subscribe to clinical key through your library links in your DHB. Ocular pathology case reviews, this is what it looks like. And if I just go and show you what it looks like, just want to share a different screen. Too many screens. Just bring this one up, and it's very good in that it's just got one page per, hang on, stop share, and I'll just stop multitasking. Index, here's my index page. Okay, ocular pathology case review. So can you indicate if you are familiar with or have this book? Yes, no? Okay. Why is it good? Because it's just got one page per diagnosis, one photo, about 3 lines of text, and then a descriptive photo. So today we were looking at keratoconus. So I just scroll down here and cornea. I want to find out about keratoconus. This is an e-book as well as a print book. It's coming. Where did it go? Oh, book chapter. Open reading mode. Oh, there's an error. Oh, for God's sake. Refresh the page. Oh, maybe it's because I logged in before.
You want to try and log in again? And
yes.
I'll go to my other
something
people.
While I fiddle with this.
Okay, so I will share screen here. So if I go to the so hopefully on the top of here you'll be able to find the class drive folder. And in the class drive folder, there's some interesting things that can help you just do that fast recall as you revise. Okay, so if you open lectures, for example, you'll see various things. For example, I'm going to look at the cornea one because we've been doing cornea today. And here in the cornea one, there's a summary of normal, then abnormal, and then some useful quick revision cases with hot tips. So we've been talking about stains recently. I will just present this. Summary of corneal stains is just thinking about it a little bit here. Oh. All right. Okay. Summary of corneal stains. So all the things that we've been talking about are summarized on this page here for staining. So it's got really useful resources like that. Please feel free to take a screenshot if you want to suddenly remember it. I don't use some of them. I definitely don't use the finding calcium in band keratopathy. I just look at it and it looks purple and it's there. I usually don't, some people, you can say you can use iron stain in keratoconus. I don't actually do that. It's not a diagnostic feature, it's just an interesting feature. So this runs through a variety of still pictures with nicely identified things and then a diagnosis. But it's always important, of course, that you don't go straight to the diagnosis.
Should we be able to see that folder now? Because when I click on it, it doesn't come up with anything in it for me.
So, okay. Could you share screen and show me the problem that we're having? Have I not shared the folder with everybody enough?
Access. I also couldn't open the folder links.
So the folder links or the, can someone share screen? I'll just stop sharing.
When I
I'm
click
showing the problem. Because if you can't see the resources, that's a problem.
You're going to share your screen, Lucy, or do you want me to do it?
Yeah, I can share screen. Hold on. So I don't know if my problem is the same as everyone else, but when I click this link.
All right. Could you go to the Google? Yeah, so that wasn't working well. Can you go to the classwork up the top left? Yeah, click on the class drive folder.
When I click this, it's empty as well, like everyone else.
Yeah, when I clicked that was empty as well. Yeah. I went through that way.
Okay, interesting.
That's why I don't know where to upload my talk either, because there's no button that says
Right, so I've probably not got the sharing things right. So I will sort that out while Amanda now talks to you about her thing.
Yes, I found it. Okay.
But it's good to know that you couldn't get there, but now we can share it.
Okay, so now I'm in the Ocular Pathology Case Reviews book, and it's just got, so today we were looking at granular dystrophy. One picture of clinical, one picture of pathological with the appropriate stain, like 5 lines of description, and then labeled histo diagram. It's quite good like that. And it covers everything that we have been through today. Like here's the keratoconus one, let's look at keratoconus. Clinical picture. Okay, this is the thing we looked at, thick and thin, bullous keratopathy. Few lines of description, one picture. So one picture, so each thing is like encompassed on 2 pages. So you can test yourself with the first page and then look at the answer with the second page. And it's the things that we've covered. So these ones on BCC, SCC, infections, just one picture per page. And that way it's a nice introductory in, and it's got the keywords that you can remember and where the things are that you're meant to look for. So I would recommend this one, Ocular Pathology Case Reviews, which looks like this on the front cover. I hope I'm sharing the right thing. And of course, if you look at the front cover, you can see what the diagnoses are on the front cover. This one here is molluscum contagiosum. This one here is granular dystrophy, and that one's a melanoma. So, yeah. There you go, it's all in front of you. Should be available from your library because it's an Elsevier Clinical Key ebook. I recommend going and getting it. And you can just have it on your device, and while you're waiting for the bus, just look at a couple of cases. All right.
I'm still trying to sort out the Google Classroom. Could you?
So shall we? So what else have we got? We've got Anki cards and exit survey. So we could sort out the drive after, I suppose.
No, I think I've got it now.
Okay.
Just going to put the, here we go. I'm going to put the link here. That's the link to the drive. And I think I've got it shared with everybody now. Would you like to, everyone try clicking on that and see if you can go to the drive?
Let's test.
I still can't see anything inside it.
Mine is working now.
Okay, the link works, but if I tried to access it from the classroom, it didn't recommend it.
Maybe it's because it's the different status of student versus teacher access to the drive.
Yeah.
If you direct access to the drive, then.
Okay, I think I've got to probably add you one by one, which I will do that one by one. Because
we could just post that link in the Google Classroom. How about that? Then you don't have to add people one by one. Just post the link in the Google Classroom. There you go.
But when they go in, they can't see the stuff?
No, we can. If you go in by the link, you can.
Yeah.
All right, when you're going by the link, you can.
Yeah. Link,
not through the classroom.
Yeah, G Drive. And I'll just put that here in the There you go. I've just posted that now in the posts above the YouTube one. So that should be, and it's on sharing, so that should be okay.
Yeah.
Yeah. Okay, so that's available.
Right, so you can all get in there now.
Yes, that's solved.
Great. Okay. Lovely. And you've posted it on Classroom, so even the people who weren't attending can get their Google Drive. That's good. Okay, so going back to the Google Drive, hopefully you will be able to now see the picture that I can see. I'll just share my screen again. Right, and Class Drive folder. Hopefully you'll be able to see that. Right. So there's lots of things that are really useful to just like flashcard things. So the first thing that's really useful is the lectures here. Okay, so particularly, I don't know, let's go through globe, tumors, and mimics. I'm just going to whiz through that. So as we whiz through that, you will hopefully see some cases, some basic instructions, and some cases. So all this you should hopefully know by now. This is how it goes. Right, so we've got cases, which tells you what things are, and you can make a diagnosis. Right. So that's fast revision. And along those lines, there's another set of fast revision things here, which is right below it. Just go back one, called the teaching CD. This is the one I gave to the college a little while ago, and again has pictures like you'll get in your exam, and then a diagnosis. So for example here, okay, something funny is happening. The eyelid, case 1. Right. Yeah, cases, pointing out features, diagnosis, and what the features were. That's a horrible picture.
Oh.
All right, okay. So that's another resource that you can use for quick revision. Some of these are quite rare cases, so don't be worried if you don't get them. Okay, then there's the molecular pathology and the genetics, which is what we are going to be doing in the last bit. How are you all feeling? I think we need a 5-minute break before we attempt genetics and molecular.
Probably, yes.
Okay, so we'll just take a 5-minute break until 20 past, and I will try and give you the best I can for genetics and molecular pathology. Amanda's good at genetics and molecular too, so between us, we'll manage it. 5 minutes, people, and I'll be right back.
4:20.